I am going to just hit on some highlights on how do we optimize recovery in youth sports, concussed kids. And in doing that, I first want to just highlight what we're doing at the ONS Foundation and our clinical goals. And that is to change the outcome, to optimize how we prevent injury and how, when a child does have an injury, we make sure that the symptoms lessen as quickly as possible, using evidence-based, scientifically validated interventions and practices. What I'm going to show to you today is the best practice model for optimizing recovery. When you look at all the literature and you look at the best practices across the country in pediatric hospitals, they all have three factors in common. The first is when a child walks through that door and they have a concussion, their goal is to improve the symptoms and reduce duration. The second factor is they view concussions as a neuropsychosocial condition. It's a neurologically based condition that has psychosocial sequelae. And third is they implement an intervention model that's focused on medical and neuropsychological factors that lead to prognosis. So as a quick overview, as I'm going to talk about recovery, is going to be the primary focus of my talk in youth. I'm not going to talk about NFL, professional sports. This focus is on youth. Looking at longitudinal studies, who takes longer and why to recover, and then how do we fill in the gaps, looking at NIH longitudinal studies, and a decision-making tree for when do you pull in neuropsychology. And then I'm going to finish this up with a critique of recovery and prevention tools that you see that are hot out there in the media. I don't think a day goes by that you don't read the New York Times. Here's something on ESPN that says, this is what's out there, or this is what's going on in youth concussions, and what do we need to do about it. So as a result, it's probably one of the most torqued up issues out there, right? Parents are extremely anxious and want to know what to do. You may not have even heard the term pediatric neuropsychology, and what it is, it's the science of behavior, emotion, and cognition in the developing brain. It's a subspecialty that gives you the functional picture behind an MRI or CT scan. So it relates brain integrity to everyday functioning at home, at school, and at play. And it's the discipline that's related in the research, diagnosis, and treatment of multidisciplinary neurological teams of diseases and traumas that are affecting the integrity of brain function. So because I'm the last speaker here, and I've got a very short window of time to talk about concussions, I'm going to engage you. So on your paper 1 to 5, you're going to take a little quiz here with me. Question number 1, let's start off with the basics. What is the definition of a concussion? A blow or jolt to the head that disrupts the function of brain and results in an altered state of neurological status. True or false? True. True. All right, good. Okay. So true. That's what it is. And the majority of cases do not involve a loss of consciousness, as we used to say. And symptoms include 4 features around physical, sleep, cognition, and emotion. The prevalence is pretty much unknown. I mean, the CDC studies will estimate that at least 3 million per year sustain a concussion, but that's underestimated because not all kids go to the emergency room or to their physician, and so we don't have a good way of tracking this. Question number 2. Let's see how you do on this one. The magnitude of force to the head is actually what causes a concussion. Oh, good. You guys are good. All right, this is false. So you may be familiar with the University of North Carolina. A lot of good things come out of University of North Carolina, out of the state of North Carolina. We got Michael Jordan, and now we got this HIT study that's come out of UNC. What this HIT study did is, what they did was they put sensors in the helmets of the football players. And these sensors could actually record the location, the magnitude, and the angular force of the hit. And what they found is it's a pretty wide range of force that causes a concussion. And that it's not just the force, but it's that the confluence of the rotational force should never be underestimated, rotational injury, and that it's not as much as the force as it could be the direction of the force. And this is going to be important when I go at the end of this talk to talk about these gadgets that are out there that talk about prevention or how you identify, because this is a hallmark study that tells us how the concussion is happening. Number 3, recovery, which is going to be really what we're talking about here. Which of the estimates below are accurate recoveries percentages for symptoms after a concussion? Majority of kids within the first few weeks to days to weeks recover, 85%. About 90% are going to recover within that first month. 90 to 95% recover in the first 3 months, and then we've got a small subsection of kids that take more than that. E, right, okay? All of these are the accurate reflections of the percentage of time it takes to recover. In 2009, Keith Yates, in a multidisciplinary study that involved neurology, neurosurgery, neuropsychology, and physical and sports medicine, looked at how a large cohort of kids over a period of several years. And this is what they came up with in terms of recovery timelines. What they also did was, how do we look at this BCD group? And how do we try to keep kids from falling into that category if they do have a concussion? And who are the kids who are at risk? So how do we ID the kids, and how do we prevent them from taking too long to recover? So what they identified were pre-existing risk factors for concussion. And so question number 4, there's medical and there's neuropsychological risk factors. Can you think of any medical risk factors?
Bleeding.
So you've got a history, so these are pre-existing before they even have a concussion. So you've got a history of neurological trauma or disease, which can include previous concussions, right? So we know that once you concussed, you are more likely to concuss, okay? It goes up exponentially with each concussion. So what about neuropsychological risk factors that could make a child at risk for longer recovery, pre-existing?
Some reading issues and memory issues.
Awesome. I don't have any books to throw at you, but that's a great answer. We've got ADHD, learning disabilities, developmental disability, and mental health history. And I'm highlighting mental health history there because this Yates study that I'm going to refer to throughout my talk, among other studies, finds that mental health is often undiagnosed in the teenager and in the college student. Okay? So we don't always know that this is a pre-existing condition until later on when we're trying to treat the athlete. There's a small subsection of kids, we don't exactly know how many, fall into this definition of post-concussion syndrome. Have any of you heard of it? PCS. This is defined as a continuation of concussive symptoms. It's primarily headache, dizziness, irritability, and mood changes that occur post-injury and persist for at least 3 months and include evidence of impaired memory or attention on neuropsychological testing. So I say we don't really know how many kids this is because it's hard to say. It's difficult to tease apart the symptoms that are presented at 3 months post-injury because we've got overlapping functions going on here, factors going on, in terms of on the bottom left, you'll see we've got considerations that are related to the neurological aspect of the concussion. Above that in yellow, there's pre-existing typical teenage kind of symptoms that happen. And then we have mental health issues. And all of these have their own symptoms that are unique, but then when they come together, we've got overlap. And teasing this apart and coming up with a diagnosis of PCS is critical. This is a really good chart that shows the findings from numerous different studies. So I've labeled it as prevalence of PCS symptoms, but that's not the purpose of the study. What you'll see on the left is how many college students or high school students have these type of symptoms, physical symptoms and neuropsychological symptoms. These are high school, college kids who've never had a concussion. You'll see how many say on symptom checklist they have headaches? How many experience dizziness? How many experience irritability, memory problems, and concentration problems? So go back to my circle. What's pre-existing kind of normal symptoms, right? Then you've got depression that you add to that, which is often undiagnosed. In depression, you've got very similar symptoms that are physical and neuropsychological. 37% of people with depression have headaches, in teens and in college kids I'm talking about. Dizziness, irritability, memory problems, concentration problems. And then finally on the bottom we've got our concussion sample, which is headache, dizziness, irritability, memory, and concentration problems. So somebody comes to you, to your office, 3 months after a concussion and says, I still have symptoms. So what do? You need to go back and you need to filter through and tease apart all the factors that could play into this. And it's difficult to tease apart for a second reason, which is over time you get this downward cascading effect of the interactive effects of these. And you add in how a family is trying to function with this. And you're dealing with a fragile coping strategy of a teenager. Their coping strategies are not developed. They're emerging. And you've taken them at a point when they are forming their identification. And in a lot of our high school kids and college kids, their identification is around sports. And so you take away their sport temporarily. They're at a time when there's a lot of academic stress, whether they put it on themselves, their parents are putting them on it, put them under stress, or their school is, and the importance of peer relationships is at its height. So how do we optimize recovery? So treatment models, again, I'm going to go back to that first slide, that view concussions as neurologically based with psychosocial condition associated with it, have the best outcomes. They look at prognosis as a function of medical plus neuropsychological. And they do two important things. One is at the very first initial visit, they are using standardized inventories to assess pre-post injury for sleep, physical, cognitive, social, and emotional functioning. There are really wonderful tools out there that are open to be used by anybody in any clinic. National Children's has a great one. That's where Jerry Joya is, who's with the CDC, who's also one of the makers of impact testing. The PEDS Quality of Life Inventory. There's great tools out there for doing this. Thorough history of academic background. And then the third thing they do is educate. It's not in and out of the office, but an education is required. The second thing they do is they determine the level of neuropsychological involvement beyond providing basic education to the family. And this is a decision tree that came out of that NIH study by Yates, which is when you need to determine the neuropsychological involvement, you want to make a decision based on risk factors at first. So, does the child have pre-existing high risks? And those are medical and neuropsychological risks. Remember, I reviewed those earlier, the medical ones and then neuropsychological. If yes, you refer to neuropsychology or you get a consult, okay? If no, you monitor and you educate. If they go beyond that 2-week period and they're starting to gradually move down and things are starting to spiral out of control, you refer. If you've got a differential diagnosis question, you refer, okay? Monitoring, educate. What do you tell that parent? So you have the 15-year-old that pops into your office with a concussion. Parent wants to know, what do I do? I'm looking for a solution. Here's what you need to tell them, is based on the evidence, the best thing you can be doing for your child is rest. That's cognitive and physical rest. Fluids, and reduce their stimulation. That's light, noise, electronics. And we want to return you as quick as we can, but safely. We don't want you going back before we decide it's okay for you to go back. And if we look at the models that have been presented by physiatry and rehabilitation medicine, this is the discipline that really looks at recovery from traumatic brain injury in terms of treatment. What they do with your more mild to severe brain injury is we try to start to stimulate when it's safe. What we want to be cautious of is this notion that I hear a lot about called cocoon therapy. Has anybody heard of this? Okay. Cocoon therapy is, I think it's unique to this part of the country. I moved here 2 years ago from Cincinnati and I'd never heard of it. But there are some parents that are being told that they need to put their child in a cocoon of no stimulation, no interactions for several days to several weeks. Okay? This is extreme and it's very dangerous. It's extreme in the sense that we're removing a child from any interactions at a time in their development that's critical for them to have some interactions. Okay? So when you hear about this, or when a parent says they want to do this, give them some feedback that this needs to be presented with caution. So, number 5, impact testing. I'm putting this up here because you're asked a lot about impact testing if you work with kids with concussions. It's out there on the market and parents want answers. So what is it? It's the test of concussion. It's a comprehensive neuropsychological evaluation. It's highly reliable. Answers B and C, or none of the above. Not quite sure? It's none of the above. Okay? No test is perfect. Every test has limitations. If you work with kids with concussions, if you are an administrator of impact, you need to know there's limitations if you want to be able to treat that kid and optimize recovery. It's one piece of the evaluation. It's a screen of some of the cognitive symptoms, and the reliability is variable. It's often given unsupervised. At least 20% of the kids who take it show poor effort. The retest reliability in controlled, peer-reviewed studies that are not done by the makers of the test show that the range of reliability is 0.23 to 0.6 at a 90% confidence interval rate. That's not good. You want 0.8 to feel like you can say to something, I trust these test results. This is retest reliability. It's often being given now, I'm finding, in kids who are less than 14. There's no standardized norms, and there's a floor effect. This was a test that was designed for adults. We can't give it to a 10-year-old and expect that it can pick up on deficits. Most kids who take it who are 10 and 11, it's too hard for even them to get any answers correct. So how are you going to be able to detect if they have a problem? And it doesn't, remember that those concentric circles? It's not going to pull out depression, anxiety in how a child performs. But here's what it is. There's some good things about this test. It can be a good post-acute screening tool when it's supervised, meaning it's one-on-one. It's not you leave the kid in an office and you leave and you come back to find out they've been texting the whole time, which is what I've heard from many patients. And you don't give it to kids with a known history of a mental health or anxiety, depression disorder, okay? It's not going to be able to tease out what's what. It can help ID players. We hear this all the time of players who deny symptoms, but you give them impact and it picks something up. But you need to use your clinical judgment. 30 to 35% false positive rate. So meaning it's saying there's something going on when it's not 30% of the time. So it's conservative, which isn't always a bad thing, but you need to put things in the context of the student and the player. So I'm going to end on, you've got that anxious parent in your office who wants to know answers to the latest things out there on the market. And when we look in pediatrics, when we look at what are solutions out there, you try to put in a paradigm of there's what's the evidence, and evidence means peer-reviewed, scientifically validated. It doesn't mean just a study that was done by the people that are selling you the product. And it means how much are we investing in it? Investment of your time, investment of your money, and investment of your hope. Now in kids, this hope piece is critical. If you put kids through something and it's taken up a lot of their time and you've said, I'm going to do this and it's going to work, and it fails, then they feel like things are even more out of their control. So you don't want to create false hope. Let's take the first one that I just recently learned about. Has anybody seen this censored chin strap? Any football parents out there? Okay, that's good. I'm glad it's not as well known then. So this is a strap that if you put it on, it will detect the velocity of the hit. So you see it in the YouTube video by the company that makes it, that we can detect whether a hit is hard enough to take the kid off the field. So number one, if there's a suspicion of a concussion, the child's removed right away, right? When in doubt, pull them out. Well, what this strap does is it tells you red or green after a hit. So if it's green, it means go back to play, you're okay. If it's red, it means no, that hit was really hard. Well, let's go back to that UNC study. It's not just velocity, it's direction and angle as well, okay? This can't pick up, it's not censored in the helmet to pick up where the hit comes from. So no scientific peer review evidence, high hope, a lot of danger. Soccer helmets, have you seen those out on the soccer fields yet? Okay, this is another one. No scientific peer-reviewed evidence. Have you seen the helmets that rugby players wear? They're kind of this soft helmet that can help protect from head-to-head bruising. Well, that's the same idea behind these soccer helmets. No evidence that it works. Again, we're not talking about just hit-to-hit outside of the head. We're talking about what that does on the impact inside from skull to brain, rotational injury in the angle. It's not going to help. High hopes. Parents will say, my kids had 2 concussions, but I'm going to put a soccer helmet on them so that they won't get a third. That's dangerous. Mouth guards. Could be. You know, we really don't know. The evidence is variable on whether I don't think they're concussion proof, but certainly they prevent jaw injury and dental injury. Low time, low cost, maybe it's something you consider. Supplements is another thing that's hot right now, and there's a lot of longitudinal studies going on with supplements. This could be promising, we don't know right now. And then the last is computerized detention programs. No scientific peer-reviewed evidence that in your acute phase this is going to help. It's a lot of time, a lot of money, and high hope. So in summary, when we think about how do we optimize recovery, we're going to improve symptoms and reduce duration by conceptualizing concussions as a neuropsychosocial model and use a risk and treatment intervention that's medical and neuropsychological for looking at prognosis. Provide neuropsychological education to all with early intervention, and know the evidence behind solutions out there so you can calm parents down when they come in. And contact us at ONS for additional resources around this or any other topics with concussions.